Okay, so let's start the class. The topic for today is HPV vaccines, and I'll be talking about the HPV virus in a bit, and then I would move into the details of HPV vaccine. I would try to finish the topic in as much by giving only that important information and leaving out the unnecessary details. And this is me first time trying a class like this, a presentation like this, so please bear with me and do interrupt if something goes wrong. Okay, before going into the HPV vaccine, let's talk about the HPV virus. HPV virus belongs to the papilloma viridae, and it can be inactivated uh, when the temperature goes up to uh, 70 degree. So it gets inactivated at 70 degree, and if we keep the virus at 50 degrees C for 30 minutes, HPV gets killed. The HPV can broadly be classified into the strains can be broadly be classified into those who have low oncogenic potential and those who have high oncogenic potential. The strains that have low oncogenic potentials are 6 and 11. The ones having high oncogenic potentials are 16, 18, 31, 33, 30, 35, 45, 51, 52, and it goes on until up to 82. So there's 55, 58, 59, 68, 73, 82, and 83. So when we look into the protein that forms this virus, so it can broadly be classified as the early proteins and the late proteins. So the early proteins are depicted as E, and the late proteins are depicted as L. And if we look into the early proteins that are there that forms this virus are the E1, E2, E4, E5, E6, and E7. Now the interesting thing is the E1, E2, and the E5. These are the proteins that are responsible for DNA replication, right? Then what does the E4 protein do? The E4 protein is responsible for the structural framework is basic. E4 is basically a cytoplasmic protein, and whenever it infects a cell, it disrupts the structural framework of keratin. So if a cell is infected with HPV, we can see that sometimes it develops spinous and horn layers of an epidermis. So this particular E4 protein is responsible for that, right? And then we are left with the E6 and the E7 protein. So what does the E6 and E7 protein do? These are the only two proteins that are responsible for the malignant transformation. So the reason we're learning about HPV is because of its malignant transformation. So what does E6 do is that E6 it attaches with the P53 protein, and it causes proteolytic degradation of the P53 protein with the help of ubiquitin ligase, and in that pathway the P53 protein is damaged, right? And also the E7 protein that binds to the RB gene, and it inactivates the PRB gene. Now once the RB gene and the P53 protein is lost, once these two are gone, so a cell has essentially lost the G2M checkpoint by virtue of the absence of P53 destruction, absence of P53, and also it loses the G1S checkpoint. So when these two checkpoints are gone, the cell can undergo an unregulated proliferation, and there is a decreased apoptosis, as a result of which the cell can go through the cycle of CIN grade 1, CIN grade 2 and 3, and finally leading to an invasive cancer. All right, up till this, should I move on?
Yes, sir.
Please repeat that some network issue from E6, E7.
Okay, so E6 and E7, these are so see the HPV virus has two types of protein, the early and the late. The E forms the early protein, and E has two proteins that are E6 and E7. So what these protein do is that E6 binds to the P53 gene. Okay, so not the gene, the P53 protein. So E6 forms a bond with E3 ubiquitin ligase, and it attaches with the P53 and destructs the P53 by doing a proteolysis, right? So once the proteolysis of P53 happens, now P53 regulates the G2M checkpoint. We know that P53 and RB are the policemen of a cell cycle, right? So the G2M checkpoint is gone. Similarly, E7 it attaches by the help of Calin2, which is another protein. It attaches to the RB, the RB to E2F complex, and that again causes the loss of G1S checkpoint. So G2M checkpoint is gone by virtue of the death of P53, and by inactivating RB gene, the G1S checkpoint is gone, as a result of which the cell can now undergo an unregulated proliferation, right? All right. Hello.
Yes, sir.
Yes, sir. Thank you.
Okay, so I'm moving on. So like I said, they have the early proteins. So what are the late proteins? The late proteins are the L1 and the L2. Okay, so the L1 and L2. The L1 is the major protein, and the L2 are the major minor protein. What this L1 and L2 are, they are basically the capsid protein. So whatever protein that forms the coat of the HPV virus and responsible for the immunogenicity of the HPV virus are the L1 and L2 capsid proteins, right? The reason I'm mentioning this is because whenever I'm trying to make a vaccine out of HPV, what I will do is that I will take the gene that is responsible for the L1 and the L2 protein, and I'll take that gene and I'll put it into an yeast cell or any bacteria, and I would make that yeast or the bacteria to grow and replicate the L1 and L2 proteins, and then I will extract that particular protein and use it as a vaccine. So that is exactly how it works. That's why L1 and L2 are important, because these particular proteins are the capsid proteins are what helps us in making a HPV vaccine. Understood?
So can you repeat that regarding L proteins?
Okay, so L proteins are responsible for the capsular capsular coat of the virus. Okay, so we know that all the virus, the structure of the virus have a capsular coat, and then inside it has the nuclear materials, right? So the capsular part is basically formed by L1 and L2. The major one is the L1 and the minor one is the L2. Now, suppose I want to make a vaccine out of HPV virus. So what I will do is that I will take, so I don't need the entire virus to make a vaccine. right? I don't need the nucleus. I don't need what lies inside. I don't need the E1, E2, E4, E5, E6, and E7. If I take all of these, then it doesn't make any sense, because I don't want the malignant potential of the virus. I just need the outer coat of the virus, so that whenever I'm introducing that into a person, that person gets immunity against the HPV vaccine, HPV viruses, and when the real virus comes in, it doesn't allow the real virus to infect the particular cell, right? So I just need the protein, the capsid protein. How do I just make capsid proteins? I take the gene that is responsible for the capsid protein, which is the L1 and the L2 gene, and I insert it into an yeast cell. So we all know, we have all studied back in class 12, there's something called single cell protein. We know how insulin used to be made. They used to take E. coli, and they used to put in their extranuclear DNA, the circular DNA, they used to put the gene sequence by using endonucleases, if I'm not wrong, yeah. And then that particular gene gets incorporated into into the circular DNA, and then when the cell proliferates, the bacterial cell or the yeast cell proliferate, it keeps on producing that particular protein. So similar way here also, if I'm trying to make a vaccine out of the HPV virus, I will take that L1 and the L2 gene, I will insert it into an yeast cell or a bacterial cell, and I'll make the cell to grow. Once the cell grows, it produces that particular protein. I will extract that protein, and I'll make an HPV virus, HPV vaccine, right? Clear?
Yes, sir.
Okay. So I'll move on to the vaccines proper. So I'll just give an overview of what vaccines we have and how do we administer them, and right. So the vaccines for HPV virus, we all know, we have 3 vaccines now. The first one is the Cervarix, which is the bivalent vaccine. The second one is the Gardasil, which is the quadrivalent vaccine. And then the newest one is the Gardasil 9, which is the nonavalent vaccine. So there are 9 strains of HPV inside in Gardasil. So what are those strains? Cervarix, just 16 and 18. The main viruses that are responsible for the cervical cancer, the main virus strains, will just take those and make Cervarix. For Gardasil, they use 4 strains. So they use 6, 11, 16, and 18. For Gardasil 9, they use 6, 11, 16, 18, along with that 31, 33, 45, 52, and 58. All right. Now let us enlist what all HPV virus associated cancers are. HPV virus associated cancers are the cervical cancer, that which we all know, the oropharyngeal cancer, the anal cancer, which has high association with HPV virus. We have penile cancers, vaginal cancers, and vulvar cancers that are also caused due to HPV virus. Moving on to the vaccines proper. So,
Sir, can you please repeat?
repeat which one?
After the 9 Gardasil.
Is there any issue with the is there any issue with the voice, or you just want me to repeat? Like the voice is coming clear, right?
Yes, sir. Voice is clear, sir.
Okay. So I talked about the viruses that are associated. Sorry, the cancers that are associated with HPV virus. I was just enlisting all the viruses, all the cancers that are associated with HPV virus. So so the cervical cancer, which we all know, oropharyngeal cancer, anal cancer, penile cancer, vaginal cancer, and the vulvar cancer. So all these cancers are associated with HPV virus. Okay, that's what I talked about. So moving on
Okay, thank you, sir.
to Gardasil and cervix. So how do we give Gardasil and cervix? So Gardasil is a quadrivalent vaccine which is given to both boys and girls. It has been proven to be effective against genital warts, cervical cancer, and anal cancer. It is given as a 0.5 ml injection, and it is given in 0, 2, and 6. So the first dose on day 0, then the second one should be given after 2 months, and the third one to be given after 6 months. As quite cervix, most of the trials, they used a regimen of 0, 1, and 6. So the first one at day 0, the second one to be given after 1 month, and the third one to be given at 6 months, right? Cervix, it was given mostly to women, not men. And for both of these, the age group that it is given is 9 to 26. 9 to 26. Okay, so the most effective age group. So this is what I'm talking about, the administration of HPV vaccine. So as far as administration of HPV vaccine is concerned, a few points on that. These vaccines can be given as early as 11 to 12, but it is mostly effective when given between 13 to it is most effective when it is most effective in the age group of 11 to 12. I'm sorry, I'm correcting myself. It's most effective when it's given in the age group of 11 to 12. It can be given as early as 9. And then, so for those people who have not been vaccinated in this particular age group of 11 to 12, there is something called as catch-up vaccine. So those who have not received the vaccine before can receive the catch-up vaccine in the adolescent age group of 13 to 20. So this is the catch-up. So this is the catch-up time, and the catch-up time can be given up till the age of 26 years. So as early as 9, most effective, or more, or rather, the most tried age group was 11 to 12. Catch-up can be given up till the age of 26 years. So does that mean we cannot give it after the age of 26 years? No. After the age of 26, where we can still give it, but in a very selected group of patients who had no or very less number of sexual partners. At the same time, we have to talk to those patients, those people, and we have to make them understand that there might be limited advantage of giving this vaccine because they might already have the infection. But as we know, the infection might be of one strain, and if you're giving the vaccine, it will be effective against the other strains of the HPV. So a study came which which is named as the VIVAN trial, VIVIANE study by Wheeler et al. And it was shown that even beyond the age of 27 years, beyond 27 years, for selected group of patients only, given this vaccine may benefit. But the age group of beyond 45 years have never been studied. Right? So HPV vaccine works best with HPV naive people. So those patients who are HPV naive, have never been infected with an HPV virus, it works best on them. Right? Okay, up till this point, is there any doubts? Do you want me to repeat something? Otherwise, I will move on to the next points that has to be discussed regarding the vaccine.
Clear, sir.
Clear. Okay. Now the next point is that even though it works best with people who have no HPV infection, that doesn't mean people having HPV infection is a contraindication for vaccination. So not a contraindication, not a contraindication. What are not contraindications? An existing HPV infection, patients who already have warts, or patients who have shown an abnormal pap smear. Moving on, what are the doses? The doses should be, if the patient is, if the person who we're supposed to vaccinate is less than 15 years of age, then they can be given 2 doses only. When are those 2 doses to be given? One at 0, and the second will be any time between 6 to 12 months. All right. If the patient is more than 15 years of age, then they have to be given 3 doses. 2 dose doesn't work, and that should be 0, 1 or 2 and 6. For those who are immunocompromised, regardless of age, 3 doses. Is there anything that you should advise after post vaccination? Post vaccination, you should give 15 minutes waiting time, because patients were shown to have were seen to have syncope. So you should try and ask the patient to wait in the same position where he or she was given the vaccination, be it lying down or a sitting down position. Ask him to wait for 15 minutes before standing up, because some patients were seen to have syncope as an effect of the vaccine. Okay, so is there any role of pre-vaccine assessment? Role of pre-vaccine assessment. There is no role of pre-vaccine assessment, right? No role of pre-vaccine assessment. What assessment am I talking about? I'm talking about checking if the patient has already HPV infection, so HPV DNA. I'm talking about a pregnancy test. So if please mind it that those patients who are pregnant or lactating, it is not recommended for them to get an HPV vaccine. But a pregnancy test is not required if I'm giving an HPV vaccine. Okay. Should I move on? Should I move on?
Yes, sir.
Sir, the HPV vaccine, is it live attenuated or hello?
Hello.
Sir, the HPV vaccine, is it live attenuated or a killed vaccine, sir?
No, it's not a live attenuated vaccine. It's a killed vaccine. It's not. It's not. Yeah, it's not a live attenuated vaccine. Okay, I'm not sure if it can be called a killed vaccine because it just contains protein or outer capsule proteins of the viruses. So I'll just check on that and get back to you. But it's not a live attenuated vaccine.
Okay, sir. Thank you.
Pregnancy or lactation is not recommended. But if
Pardon? Hello.
sir, if pregnant and lactating, HPV vaccine is not recommended, sir.
Yes, I'm coming to that. I'm coming to that. Okay, so what I'm saying is that if the before giving the vaccine, it's not necessary to do a pregnancy test to see if the patient is pregnant or not. But it is not recommended in patients who are pregnant or lactating. I'm coming to that point. Just something that needs to discuss is that post-vaccination also. Even post-vaccination also, there is no role of doing a viral serology, right? No role of serology, right? What I'm talking about when I'm talking about the pregnancy and lactation is that it is not recommended to give vaccines in pregnancy or lactation, but lot of inadvertent but lot of data from inadvertent use has been coming up. Data from have been coming up. So from these data, it was found out that HPV vaccine in those patients who are pregnant or lactating is quite safe. So it is safe to give the vaccine, and lot of data, and that data is also reassuring as far as efficacy of the vaccine is concerned. But it has not been tried in any of the trials by giving this vaccine to pregnant or lactating women, and that is the reason we are not recommending giving the vaccine to pregnant or lactating women. But at the same time, you need to keep this in mind that a lot of data is coming up, and it has shown that this vaccine is quite safe if you give in those patients who are pregnant or lactating. Am I clear? Is it clear up to this? Okay. So what about the patients who are immunocompromised? Is it safe to give vaccines in the immunocompromised? Yes, because it's not a live attenuated vaccine. It is quite safe to give this in to the patients who are immunocompromised, especially the patients of transplant recipients, HIV, having CD4 counts less than 200 cells per microliter. In those kind of patients, it can be given. So it can be given in immunocompromised, and it can be given up till the age of 26 years. What are the side effects? The known side effects are the vaccine-related thromboembolism has been shown as one of the known side effects, and other side effects include, or the risks include an anaphylaxis. Other possibilities are pain at the site of the injection, fever, and headache. Okay. So if you're done up till this, I think we can move on to the vaccine trials. There's not much to say about the vaccine trials, but I would still mention about the vaccine trials. So are we done up till this?
Yes, sir.
Vaccine trials. So bivalent, quadrivalent, and nonavalent. Just bear with me. There is some technical issue. Just bear with me. Okay. So for the quadrivalent vaccine, which is basically the Gardasil, the trials are Future 1, Future 2, and the Future 3 trial. And these trials came in the year 2007. What the Future 1 trial, basically they checked with 3 doses of vaccine, 3 doses of the quadrivalent vaccine versus placebo. And the endpoints were incidence of genital warts, vulvar or vaginal intraepithelial neoplasm, so VIN or VAIN, incidence of CIN any grade, and any adenocarcinoma in situ, that are associated with HPV types 6, 11, 16, and 18, right? And the patients, and it was seen that it is 95% effective against all grades of cervical lesions. 95% effective against all grades of cervical lesions. So that was Future 1 trial. In the Future 2 trial also, it's a phase 3 trial for the for the same Gardasil, the Future 2 trial, and there were around 90 study sites in around 13 countries. And it had vaccine groups and placebo group. The vaccine group had around 5,000 subjects, and the placebo group had 5,260 subjects. And it again prevented almost 98% of 16 and 18 related high-grade cervical lesions. Right. So the endpoints again in this particular study was CIN grade 2 or 3, adenocarcinoma in situ, and cervical cancers related to HPV 16 and 18. And they excluded pregnant patients, patient with more than 4 sexual partners, and patient who had upfront an abnormal pap smear. And these patients were asked to use contraceptives all the while during the course of the study. And a 3-year follow-up was done, and they concluded that women who had not previously been infected with HPV 16 and 18, the vaccine had significantly reduced the occurrence of high-grade CIN related to 16 and 18 than that of the placebo group. So again, the endpoint was simply uh, decrease in occurrence of high grade CIN. Okay. Why I'm stressing it at this point is because I would briefly touch upon the controversies that are associated with HPV vaccine later on in the in the course of this discussion. And in none of the studies, it was the endpoint was cervical cancer, invasive cervical cancer. All of them had surrogate markers, and these surrogate markers are CIN 2 and 3. Okay, now coming to the studies associated with the bivalent vaccine. So the bivalent vaccine study, there are two, the Patricia study group and the Costa Rica vaccine trials. Okay, so what does Patricia stand for? Can anyone try this answer? What does Patricia stand for? Does anyone know? Are you all there? Okay.
Papilloma trial for carcinoma in situ.
Yeah, right. Papilloma trial against cancer in young adults. So papilloma trial against papilloma trial against cancer in young adults. Okay, so it was a randomized. Okay, so it was a randomized phase 3 study, again double-blind study, and the strains of the viruses were used were only 16 and 18, and women included in the age group of 15 to 25, and exclusion criteria was more than 6 sexual partners. The regimen was 0, 1, and 6. Like I said, cervix, the regimen is 0, 1, and 6. And again, it had the arms. They try to check for the immunogenicity. So immunogenicity was compared between HPV vaccine and a hepatitis A vaccine, and it was seen that efficacy is highest in the age group of 15 to 17 years. So highest efficacy in the age group of 15 to 17 years. Okay, and the efficacy progressively decreases as we go beyond uh,
Sir, are you there?
am I audible now?
Yes, sir.
Yes.
Okay, so I'm almost done with the discussion of HPV vaccine. I don't think I've skipped anything. Whatever I have given is enough for writing in an in a DNV question if a question comes on HPV vaccines. So if you have any question, you can ask at this point. Otherwise, I would move to a slightly different discussion on HPV vaccines. Any questions at this point?
Sir, let's continue.
I'm sorry, can you repeat? I couldn't hear.
So we can continue.
We can continue. So I would like to show you some of the slides about since Mukti ma'am could not join. This is her presentation. So I would be showing you some of the slides of the presentation, and then we can end the session. If you have any doubts, you can ask ask questions after that. So this is Mukti ma'am's presentation. Since she couldn't join for some issues, the topic of the discussion was of this seminar was HPV vaccine to prevent cancer cervix, to give it or to give it or to give it up. So this we have already discussed what all cancers that are caused due to HPV vaccine, what all strains, what are the low risk, oncogenic risk and the high risk categories of HPV viruses. This is a discussion we had in the beginning about the proteins that are present in the HPV virus and how E6 and E7 are responsible for damaging the checkpoints, as a result of which CIN HPV uh, lesion grows from a CIN grade 1 to CIN grade 2 and 3, and finally an uh, invasive cervical cancer. The thing that we need to check is the natural history of the HPV infection. So HPV infection, whenever there HPV infection can have a spontaneous clearance on itself. So 90% of the cases, whenever HPV, the person gets infected with HIV, 90% of the cases they do spontaneously regress. In 10% of the cases, what happens is they get infection with leading to a high risk cervical interepithelial neoplasm, and they again these CIN lesions can spontaneously regress. So 80% of them spontaneously regresses, and only 20% of these cases of the invasive cancer do progress into an in interepithelial cancer to progress into an invasive cancer. And whenever screening is done in these kind of cases, they usually do not progress because they are early detected and treated. In absence of screening, they may progress to uh, uh, cancer. So HPV vaccines, we have talked about the strains, the trials, the future one and future two of the quadrivalent trial, vaccine trial, the Patricia and the Costa Rica that came in 2012 and 2014. For the bivalent, these are the safety and efficacy that were checked of these landmark trials. So for a Gardasil, the main endpoints and the safety and efficacy was shown in the anogenital and anogenital CIN2 plus lesions. So the significance was seen in the lower grades only, which the vaccine was shown to be efficacious in decreasing lower grade lesions only. However, in the Cervarix trials, it was seen that CIN3 and CIN2 lesions are being decreased by vaccinating, and the long-lasting immunogenicity is also present after vaccinating. The follow-up data is, however, limited because the follow-up for immunogenicity is at 4 years only, and HPV vaccine in 16 and 18 are checked only for the surrogate markers. So like I said, only the surrogate markers were checked, no invasive cancer were checked. Because you have to think of it this way: if a person, we have talked about the age group in which we do give the vaccines, and that age group is only 11 to 12, 13, maximum 26 years. But what is the age group of the patient when a patient walks into the OPD with the cervical cancer? They're mostly in the elderly age group. So how long follow-up do we need if we need to say that it does prevent an invasive cancer? It should be at least 20 to 30 years of follow-up. But the maximum follow-up in all the trials that has been done for all the HPV vaccines were only up to 9 years. Secondly, if you do some research on all the vaccine trials, and you would see that all of these trials are being promoted by the pharma companies. Now, the HPV vaccine is being recommended by CDC, WHO, FOXI, Indian Academy of Pediatrics, European Medicine Agency, but there is a confusion. Why is there a confusion? because not all cervical cancers are caused by HPV 16 and 18, first of all. Second, there is a need to infect the women before they
Sir,
are.
the audio is breaking up.
Hello. What about now? Is it still breaking up?
It's okay for us, sir.
Okay, then maybe it's a local issue. I'll continue. Please interrupt me if it's still breaking up. Okay. Natural history of cancer cervix is that it has a very long induction phase. So throughout this phase, one needs to follow up if we need to see that if it is actually decreasing the incidence of cancer. Unanswered questions are overall vaccine effectiveness. Does it actually prevent death? Does it actually decrease any disability from cancer, from cervical cancer? What is the duration of protection? Because we do need longer follow-up. Is there any need for boosters? And is it uh, cost effective? So even after 10 years of introduction, the global HPV vaccine uptake remains very low. So even in India, we know that HPV vaccine is not a part of the immunization schedule, if I'm not wrong. It's not a part of immunization schedule yet. And countries that are most at risk are the countries who are least likely to have introduced the vaccine because of the cost associated with the vaccine. Are there other details which I would rather not go? If Mukti ma'am was here, she would have talked about it. So I would like to end the particular session here and not talk about any other controversies. So is there any question and or is there any question and please give me some
So
feedback.
can you please show that slide in which Indian scenario regarding HPV vaccine is given?
This one. So yeah, if you look
Yes.
at the Indian scenario, so the bivalent vaccine, like I said, it is the antigen expression system is the baculovirus. This is something that I have talked about. So it's either baculovirus or yeast. So quadrivalent vaccine is made using using yeast, and bivalent vaccine is made using baculovirus. And then there are some adjuvants that are being added to increase the immunogenicity. So that is alum for the quadrivalent vaccine and AS04, which is basically aluminum hydroxide, and 3-deacetylate monophosphoryl lipid A. Both are intramuscular injections. 0.5 ml is the amount dose that is being given. Quadrivalent vaccine 026 and 016 for the bivalent vaccine. This is something I've talked about. And the disease prevented as per the trials are anogenital cancers as they claim to be. Although invasive cancers were not shown in any of the trials, you need to keep that in mind. They are precursor lesions, obviously, subset of head and neck cancers, anogenital warts, laryngeal papillomas, and anogenital cancers for bivalent vaccine, and their precursor lesions, subset of head and neck cancers. And this was just a comparison of cost between these two vaccines. I'm not sure what is the cost of Gardasil 9.
Okay. Thank you, sir.
Gardasil 9 costs something around 3,500. Okay.
Okay, sir. Okay, sir.
And many hospitals are running on a charity basis for promoting women health. So the discounted cost might range somewhere between 2,000 also. But if it is someone is trying to purchase it, it costs something around 3,500.
Okay,
Sir, 3,500 per vial, sir.
Yeah, per dose.
Oh, okay.
Nice
So then,
presentation, Riddhi. Actually, I was going
so
for the
one more
questions.
doubt.
Yeah.
So any data regarding head and neck prevention in head and neck oropharyngeal vaccine?
It's an interesting question. Riddhijyoti, please take this question.
No, sir. Actually, I have I've gone through some of this, the trials. I don't think there is any data regarding prevention of HPV, prevention of oropharyngeal cancers as far as HPV is concerned. There are no such trials as of now.
Mhm.
If someone else can find out something, they can add. But I did go through some of the some searches, and I did not find any trial as such that has checked oropharyngeal cancers as an endpoint.
Yeah, true. It mainly is cervical and vulvovaginal anogenital cancers.
Yes, sir.
Okay. In fact, I was going through the questions in the chat room. I actually, to be very honest, I missed some part in between. The issue of missed dose. What happens if someone misses 1 dose or 2 doses?
Yes, sir. If someone misses 1 or 2 doses, they need to start again, sir, from the beginning. So that is what catch up means. It means for those who have not been vaccinated, or for those who have started their vaccination but could not complete it for some reason.
Yes,
for
absolutely.
For them, there's a catch up.
Yeah, that's the answer. Second, just one thing related to this missed dose. This Costa Rica trial, actually, the long-term updates showed that if someone took only 1 dose and subsequently missed 2 doses altogether and never taken the second or third dose at all, that single dose also remains very effective for a long time. So now actually coming the question of whether single dose vaccine is good enough or you need to give 3 doses. That may be the topic of future research.
Yes, sir. Yes, sir. I agree, sir.
And then there was another question. I think someone asked factors for beyond 27 years.
27 years.
Someone asked about why the efficacy is in young group, highest efficacy in what age group?
Yes, sir. The highest efficacy, like I mentioned, was in the age group of 11 to 12, and that was the highest efficacy. And what I discussed was beyond 27 years of age. There were some trials like the Vivian study that has checked for patients beyond the age of 27 years, and they have shown that as per the study, these age group of people do benefit from giving vaccines, because it is quite likely that these people are infected with one particular strain of the virus, and whenever I'm giving a quadrivalent or a bivalent vaccine, maybe the other strain will work against the infection. But but it should be given for selected people only, and what selected criteria that you should look for are those who have less number of sexual partners or no sexual partners.
True, very true. Very true. So I think you have covered everything very nicely.
So, thank you, sir.
Any other question from anyone? I really get surprised to see this such amazing enthusiasm to attend classes till 10:30, 10:40, 10:45.
There was a class that went on till 11:10, sir.
Yeah. This young generation, they are amazing.
Yes, sir.
These youngsters are amazing, really. Okay, nice class, nice talk.
Yes, sir. So
I think, if I am not wrong, correct me. As per the evidence, beyond 45, there is no indication of giving. So
no
till
indication,
45 years of age, you can still consider.
Yes,
the important thing, other than considering the factors alone, whenever you are advising this to any patient, it remains very important to counsel properly.
Okay?
Yes, sir. You can still go ahead with this vaccine, but understand very clearly that the quantum of benefit is going to be less. Right? So that woman is not going to have the equal benefit
as
been done at her age of 11, 12, 15 or 25 years of age.
Yes, sir. Yes, sir.
So that part always remains very crucial whenever you are giving those things or doing that thing.
Yes, sir. Yes, sir.
Yeah, so Dr. Bitan had some question. I just answered the question. So always make it sure that the patient knows that the quantum of benefit would be less. Right?
Right.
Okay. Nice talk. Nice presentation.
Yes, sir. Thank you, sir. So, Tanvi sir is also there. Sir, would you like to add something or comment something, sir? Dodul sir, I'm really proud that you. Yes, sir, Tanvi sir, please.
No, Riddhi, I think Dodul has already added. So it's always important that you have to mention the benefits, and exactly giving this, how much benefit you are giving to that individual. That's very important. So still that's the reason because say this is a forum where I don't like to debate it and make it like a controversial issue. Your topic was to speak about cervix vaccine and you have spoken. We should not make it like a debate and start confusing the students that whether we should give or whether we should forgive or forego. So don't do that. So
Yes.
you have explained it very nicely. So we should go by the basics, what you've explained and what is the benefit about it. Because we are not in a forum where I have to debate with you that should I give it or not give it. So already Dr. Dodul has explained. He explained it to the patient and we'll take a call. That's all. Okay. So don't make it a debate, Riddhi. You've explained very well. Just continue that. Okay.
Yes, sir.
Okay.
So, okay. So before I end the session, just want to put a question forward. So, okay. So, should I end the session here, or do you want to discuss something on the cervical cancer screening? Do you want to discuss something on cervical cancer screening, or should I just call it a day and put that discussion for some other day? Can you please answer? So I would decide on that, and I would end the session here.
Continue, sir.
Please discuss.
You want to discuss on
Maybe another day, sir.
Another day.
another day?
Continue, sir. Continue.
Continue, sir.
No, sir.
So the house is divided here. What do I do? Just okay. I just a few points I would like to discuss in short, and then I think rest of the thing I would provide provide a PDF maybe. Just give me a second. Okay, so I would just like to discuss in very short about. Are you guys all there?
Yes, sir.
Yeah. So just a few points about vaccination and about screening in cervical cancer. So if because this question has come in DNV theory exam, so it's mostly a theory question that we need to answer. The screening in cervical cancer. So as far as the recommendations go, you need to know the FOXY GCPR recommendation. So you all know what FOXY stands for. I'm not going into the details of that. GCPR is basically good clinical practice recommendation. Basically, this is the Indian guideline for screening of cervical cancer. The modality that are there in cervical cancer screening are the HPV testing, can be a primary HPV testing, or it can be co-testing. So co-testing means testing it with a cytology. So so HPV testing plus cytology, that is called as co-testing. And other modalities are just doing a cytology in cytology that is not associated with HPV testing. doing a colposcopy and biopsy, and visual inspection with acetic acid. So these are basically the modalities that we use in a good resource setting. So Foxy GCPR divides it into a good resource setting and a limited resource setting. So in a limited resource setting, the modalities that are available should be visual inspection with acetic acid and colposcopy and biopsy. Anyway, so target age group. The target age group uh, for a good resource setting should be in the age group of 25 to 25 to 65. That should be the target age group in India. Minded, this number is different for as far as an American guideline is concerned. So this is 21 as per the American guidelines, but in India the target age group is 25 to 26, not 21 sorry, 25 to 65, not 21 to 65. In a limited resource setting, this is again 30 to 65. That should be the target age group. Age to start, if we are starting with an HPV testing only, so if you're starting with HPV testing only, then you are supposed to start at 25 years of age. But if you are starting with co-testing, so instead of HPV testing only, if you are doing co-testing, that is HPV along with cytology, then you can directly start at the age of 30. Right? In a limited resource setting, also you should start at the age of 30. How frequently should you do? How frequently should you do? The frequency should be, if you're doing a co-testing, then it should be done every 5 years. If you're doing cytology, then it should be done every 3 years. So if you're doing a primary HPV testing or a co-testing, for both HPV testing only or a co-testing, it should be done every 5 years. Cytology testing every 3 years. Okay. And if in the same, in a very limited resource setting, you can do it every 5 years, and at least 1 to 3 times in a lifetime is good enough in a limited resource setting. But in a good resource setting, you should do it every 5 years if you're doing co-testings. If you're doing cytology only, every 3 years. When should you stop doing it? So age to stop the screening, so age to stop screening should be 65 if the woman did not have any like if she had consistently negative results in the last 15 years, then stop at the age of 65. So no high grade lesions or anything in the last 15 years, then stop at the age of 65. Women who did not have any prior screening should undergo at least one at the age of 65 years. And if it is negative, then she can just exit screening. So if a woman has come to you who has never done screening and she's about the age of 65, you can do just one, and if it's negative, she can exit screening. She doesn't need any screening at all after that. Follow up after, if a person has been diagnosed with any kind of a cervical cancer or treatment, if after that, how do you need to follow that up? So follow up after treatment, or any method, or any like for example, a person has uh, was shown to have a high grade lesion, and then uh, you have done a follow up test on that person. So how do you follow up after that? So for that, like if the person has shown any high grade lesion, you should do cytology or HPV testing every 12 months until she comes as negative. In a low resource setting where you don't have cytology or HPV testing, you can just do a visual inspection with acetic acid every 12 months until she turns out to be negative, until that lesion regresses on its own. And screening following an abnormal report should be at least 25 years. So if it is more than if it is more than CIN2, and irrespective of how we have treated CIN2, irrespective of if we have gone and treated the CIN2, or so it's more than equal to, if or if it regressed on its own, we have to screen for at least 20 years after that. So that's about it. And I don't, for just briefly, I'll touch upon what the American guidelines say. So American guidelines are the American Cancer Society guideline, ACS, and the American College of Obstetricians and Gynecologists guideline, so ACOG. And they say that screening should be started at the age of 21 years, not less than 21. Less than 21 should not be screened. Annual screening is again not performed here. Age group between 30 to 65 should not be screened annually. Cytology, so if you're testing by cytology in the age group of 21 to 29, 3-yearly cytology should be done. Or if you're using a conventional, so basically cytology from the age of 21 straight to the age of 65, you should do a 3-yearly cytology. I think it is not much different from what we follow in India. And if you are doing a co-testing, then again it should be done 5-yearly. So co-testing should be done 5-yearly. If only cytology, then it should be done 3-yearly. That is what I'm trying to get at. And yeah, that's it. If the person hasn't shown any high grade CIN or high grade lesions, so CIN2 or anything higher than that, if the person hasn't shown that ever in the last 20 years, then when the person reaches the age of 65, she should exit screening. Mind it, this same value was 15 years in the Indian counterpart. Okay, so according to the Indian guideline, if the person hasn't shown any high grade lesion, CIN or higher than CIN in the last 15 years, she can exit at the age of 65. Here, if she hasn't shown anything in the last 20 years, she can exit screening. More than 65 years of age, unless and until the person has CIN2, 3 adenocarcinoma in situ, the screening this should be for 20 years only. Screening should be for the next 20 years. So screening should continue beyond at the age of 65 only if the patient had a CIN2 or CIN3 or adenocarcinoma in situ, and it should continue for 20 years since the lesion has been treated. Okay, and that's it. Bimanual examination is not recommended in any of the age groups, and screening should be same amongst those who are vaccinated and the general population. So there is no different screening between those who are vaccinated and the general population. That's it. There are further details, intricacies of it, what to do, how to treat if a report comes positive. I would rather not discuss this today. We can discuss it some other time since it's already late. I would like you to comment on this, and we would end the session today. Those who are attending can please come in. Hello.
Sir, any difference in HIV patients, retropositive patients?
No. There are no such. No such. I haven't found any such thing in the guideline as far as HIV positive was concerned.
Okay, sir. Thank you.
Any other questions? Otherwise, I can leave the discussion here. End it. Call it a day. Okay. Thank you all.
Thank you, sir.